Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, the use of bisphosphonates and denosumab in patients with kidney disease. These medications are important for the nephrologist to be aware of for a couple reasons. First, they're often used in the treatment of hypercalcemia and multiple myeloma, conditions that are often associated with acute kidney injury. And second, there is potential adverse renal effects, nephrotoxicity for bisphosphonates, and potential severe and prolonged hypocalcemia with denosumab. But before we get into it, make sure to check out the other videos at this channel. Check out bcnephro.com, where you'll find articles not only on this subject, but on a wide range of nephrology topics. I'm also on Instagram at bcnephro. Let's get into it. Bisphosphonates and denosumab exert their effects by impairing osteoclast function. Bisphosphonates have direct toxicity to the osteoclast, and denosumab does it by inhibiting an enzyme called rank ligand, which is important in osteoclast formation and function. These medications can be used for osteoporosis, treatment of severe acute hypercalcemia, and treatment of malignancies that are associated with bone disease, most commonly myeloma, and several solid tumors such as prostate, breast, or lung cancer, which commonly metastasize to bone. So we'll start with the bisphosphonates. We are not going to talk about oral bisphosphonates that are often used for osteoporosis because they're not associated with any significant nephrotoxicity. However, there are two intravenous formulations of bisphosphonates that are commonly used. The first is Zoledronic acid, which goes by the name Zometa. The second is Pamidronate. Now, bisphosphonates are renally excreted, so if there's a decreased GFR, the levels will be higher. The toxicity is associated with these increased levels, also associated with a higher dose or a more rapid infusion time. Of the two intravenous bisphosphonates, when used for malignancy, Zometa Zoledronic acid is the preferred for a couple reasons. First, there typically is a much shorter infusion time, 15 minutes as opposed to 2 to 3 hours for Pamidronate. Second, is considered to be more potent and more efficacious treatment in these malignant conditions. However, it is associated with nephrotoxicity, specifically acute kidney injury on the basis of ATN, and this most commonly has been reported when it's been used for multiple myeloma, a condition that's also often associated with acute kidney injury. Now, Zometa is typically given in a 4 milligram dose. It can be given in an 8 milligram dose, and there's increased risk of nephrotoxicity with this higher dose. It typically is given over an infusion time of 15 minutes. If it is given on a more rapid infusion time of only 5 minutes, which is not recommended, there can be associated nephrotoxicity. Because of the risk of ATN, it is recommended not to use if the GFR is less than 30. If there's a patient who has chronic kidney disease or a prior history of acute kidney injury associated with this medication, and you need to continue its use, you'd want to make sure to stick to the lower dose and maybe even extend the infusion time from 15 to 30 or even 60 minutes with close monitoring of the kidney function before each dose. However, this is not commonly necessary as there's two other options. The second option is the other intravenous bisphosphonate, Pamidronate. Now, this medication also has nephrotoxicity, but the nephrotoxicity associated with this medication is not ATN typically. It's something called collapsing FSGS, focal segmental glomerulosclerosis. So this is a nephropathy, so there will be nephrotic range proteinuria. There often is associated kidney dysfunction with this condition, but there's not the same risk of ATN. In these cases, I would make sure the patient is well hydrated first, particularly if the presentation is hypercalcemia, as hypercalcemia tends to cause polyuria, hypovolemia. I would use an attenuated dose. Instead of 90 milligrams, which is the typical dose, I would use 30 or 60 milligrams and extend the infusion time from 2 to 3 hours to 4 to 6 hours with close monitoring of renal function. If the patient is on this medication chronically, you're going to want to make sure you monitor proteinuria periodically every 3 to 6 months. Now, the other option in patients with kidney disease is the use of denosumab. So denosumab is typically administered subcutaneously. When used for osteoporosis, it's used every 6 months at a dose of 60 milligrams. When used for malignant indications, it's used more frequently at a dose of 120 milligrams. For treatment of hypercalcemia, it can be used at either the 60 or 120 milligram dose. Now, this medication is not renally excreted, and it is not considered to be nephrotoxic, so it's safe in this regard. However, there is a risk of hypocalcemia which can be severe and prolonged in patients with kidney disease. Now, patients with kidney disease are prone to hypocalcemia. The kidney synthesizes the enzyme 1-alpha hydroxylase, which converts vitamin D from the inactive 25-vitamin D form to the active 1,25-vitamin D form. And with chronic kidney disease, this process is often impaired. So when this medication is used in patients with chronic kidney disease, there is about a 10% risk of hypocalcemia. Now, in most cases, these are going to be asymptomatic. When it is used in patients who are dialysis dependent with end-stage kidney disease, the risk of hypocalcemia is greater, maybe 25 to 40%. The nadir calcium level typically occurs between 1 and 3 weeks, 7 and 21 days, and the half-life of this medication is about a month, so the hypocalcemia can persist for 1 to 2 months. When it is used in patients with kidney disease, except if you're using it for hypercalcemia, you would want to make sure to check a couple things. First, make sure you check the calcium and magnesium prior to giving it and replete if necessary. I would also check the 25-vitamin D level and replete the vitamin D stores. And I would treat secondary hyperparathyroidism with active vitamin D, such as calcitriol, particularly if the alkaline phosphatase is elevated. Now, if the alk phos is elevated, this is a risk factor for hypocalcemia after denosumab, because this alkaline phosphatase may not be liver, it may be bone derived, and may be a marker of secondary hyperparathyroidism. After use of the medication, I typically check the calcium after 1 to 2 weeks. I counsel the patient on the symptoms of hypocalcemia, including paresthesias, perioral or peripheral, and muscle spasms. In patients who are dialysis dependent, I would check the calcium weekly for 2 months after his administration. So that's it. Thanks for watching. The use of bisphosphonates and denosumab in kidney disease. If you made it this far, you might as well hit like and subscribe. Leave a comment if you have experience or questions about the use of these medications in patients with kidney disease. And until next time.